I first of all would like to thank the Ophthalmological Society for inviting me for this. Dr. Adit Porwals and Dr. Saradi Vyas Madam is also there, the chairperson, and if you on the dais, and all my dear friends. So just few points, what we discussed. Vitamin A, trehalose, and hyaluronate are known to increase the electroplasia of epithelial cells, cause electroplasia. So they can cause a regression post-LASIK. So if you are giving hyaluronate post-LASIK, then you should avoid it because it can cause regression of the corrected error. So that's one point. So you can just give plain CMC like refresh or something or whatever you like. But giving hyaluronate post-refractive surgery can cause regression because of the hyperplasia. Second, insulin is a epithelial growth factor and it tends to heal the epithelial defect but does not improve the nerve corneal sensation or what we call as the corneal sensations basically. So you might have a partial or a temporary effect, but after some time it will again lead to epithelial defect once you stop the drops. Then regarding soft steroids, we all have no, you're not sure whether fluoromethalone or loteprednol is a soft steroid. But technically only loteprednol is a soft steroid. Even fluoromethalone gets absorbed into the anterior chamber and causes a rise in IOP. So if you want to give a long-term soft steroid, it should be loteprednol and not fluoromethalone. So that was the third point. And the last point was about tacrolimus and long-term use. As of now, I have discussed with some of my colleagues from LV Prasad and all. They have not yet found any long-term side effects. Although, as Dr. Prafulla said, that there could be ocular softness neoplasia as a side effect, but in none of the studies they have mentioned this, and it's the overt tacrolimus that can cause this side effect, not the topical. So, and regarding the newer molecules, the Lifitegrast and cyclosporine, you can, as of now, there is no restriction. You can give as long as you want because there are not. No, I can suggest with another step, Dr. Prafulla, and then we'll come to know about it. So let's come to my talk today. It's not my talk. This was just a case. There is no folder.
Yes. So, sir, yes. So, primary bits attack.
So, we'll quickly go through this presentation of this molecule. Lifitegrast, tackling inflammation in modern dry eye management. So, there is a huge burden of dry eyes in the world. It's about 344 million as per the last count, mostly older patients. And there is an inflammatory cycle. We have all discussed this in the previous talks. The most important part in Lifitegrast is the interaction between two basically the receptors of LFA and ICAM. LFA is basically a receptor on T cells and ICAM is secreted by the corneal and trabecular cells in response to dry eye. Now what Lifitegrast does is blocks the LFA receptors, the area where the ICAM attaches to LFA, and because of that, the T cell activation is prevented. So compared to cyclosporine, the cyclosporine acts inside the T cells. It acts on the nuclear complex of the T cells to release interleukins. However, Lifitegrast acts on the external surface, and therefore it prevents not only the activation but also the migration of these cells to the surface from the local lymphocytes. Therefore, the action of Lifitegrast is faster than cyclosporine, and also its solubility through the tear film is better because it's not oil based as compared to cyclosporine. So therefore, why they say that Lifitegrast acts faster is because of this particular area of action of this molecule, the ICAM LFA complex block, and activation of T cell, activation as well as migration. So this is all the basically the graphic representation of what I just said, and ultimately decrease in the number of T cells in the corneal or the conjunctival stroma can ultimately lead to decreased inflammation and the cycle reverses. And therefore, somebody asked, when should we introduce Lifitegrast? Lifitegrast can be introduced even earlier. The reason being, sometimes the inflammatory cycle reverses because the tear film secretion is good, it dilutes, the hyperosmolarity gets reversed. But everybody may not have the same capability based on the environment in which they work. And you may initially want to start Lifitegrast to reverse this cycle and then maintain on lubrication. So that is another view of using Lifitegrast. Instead of directly waiting for SPKs to form on your cornea and filaments to come and then I start Lifitegrast. So Lifitegrast can be used initially for certain people who have this history of long-term computer use, post-menopausal dry eyes, and many other conditions which are associated with immunological dry eyes, which need to be addressed earlier rather than waiting for things to become irreversible. Because then in that situation, you may need even further longer dosage as well as oral medications. So therefore, the other view of starting this molecule would be to start early and then maintain on basic steroids once you reverse the cycle. So this is the slide which I was saying, why target inflammation early. And between the two molecules we just spoke, cyclosporine acts on the calcineurin receptors while Lifitegrast acts on the LFA-ICAM complex. Therefore, its action is faster. They say 2 weeks, but technically I found about 3 weeks, 15 to 20 days is what I usually get responses. And in cyclosporine after a month or two, even 2 months. And the trials we just spoke of, the various Opus 2, Opus 3, and they all deal with the efficacy of the molecule, the eye dryness score, improvement, the ocular discomfort, and the side effects. They have found that in the long-term use, that Madam just said day 84, not week. So they have seen sustained improvements and no side effects as such. This Sonata trial was about long-term safety of the molecule, and it had only few local effects like change of taste and irritation, and some mild visual acuity reduced maybe because of the irritation itself, but nothing directly related to damage to the ocular surface. So real-world impact, we have seen how it has improved the satisfaction score in various patients, including the OSDS score. Our experience, that is, we conducted a pilot study of 15 cases at our institute, and we had about 3 cases of Sjogren's syndrome, primary and secondary. 3 were post-menopausal, 4 were post-operative dry eyes, both after cataract and trans-PRK LASIK, and 5 were trans-PRK procedure, and 5 were heavy screen users more than 10 hours per day. The method we followed was, we administered it twice a day for 6 weeks, and the parameters were measured at 50 days, 1 month, and 6 weeks. In 5 patients who were of the post-operative type, these were all patients with chronic dry eyes on cyclosporine. So we stopped the cyclosporine in one eye and started Lifitegrast, while the other eye we continued cyclosporine. And we measured the response based on subjective OSDS score and objective like Sherman's test, tear breakup time, and the Sika score. Sika score actually looks at the steady pattern, and it is score is up to 12. Anything more than 3 is considered having Sjogren's syndrome or dry eye head. It's actually meant for Sjogren's syndrome, but you can consider this score anything more than 3, or nowadays they say up to 5 is also allowed, but after that it becomes severe dry eye. So all the patients except 2 said that there was an improvement in subjective symptoms like readiness and body. So out of 15, 13 said they had definitely felt some difference, that readiness and the body sensation had gone. While the 2 who didn't improve were cases of chronic primary Sjogren's syndrome or already pumped plugs and syrup drops. And all patients showed improvement in about 2 to 3 weeks after starting the treatment. The objective scores that we saw out of the 14, after the 15 patients, 14 patients showed at least one parameter had improved. 8 patients who were screen users and the post-operative ones showed improvement in all the 3 parameters. 4 patients showed one post-op, 4 patients, that is 1 post-op patient, 3 post-menopausal showed improvement in Sherman score and tear breakup times with not much change in the Sika score. And the 2 patients of Sjogren's syndrome showed improvement in only the Sherman's values. 1 patient did not show any significant improvement in 6 weeks. The level of improvement was rated significant if it was more than 10% of the original value. And all patients where the drug was administered in one eye expressed subjective improvement with significant improvement in the objective parameters. So compared to cyclosporine, there was some additional benefit in these patients that we noticed. All the parameters either improved or remained improved and stable after 6 weeks. There was no worsening over the period of the study, and none of the patients showed any major adverse reactions or intolerant side effects. 2 patients reported congestion with irritation in the eyes. In conclusion, Lifitegrast has a faster mode of action, which is visible within 2 to 3 weeks subjectively and in few cases objectively as well. Lifitegrast is a good alternative to cyclosporine. It can be given as an adjunct to cyclosporine, as Dr. Fakul said, because it can help in covering the remaining lymphocytes which have escaped the effect of cyclosporine. And Lifitegrast is effective in moderate to severe dry eyes, but less effective in very severe dry eyes. So there you might need oral immunomodulators, as again what Dr. Praful said. And Lifitegrast is well tolerated by most patients. So thus, with this personal experience on the use of this molecule, it enhanced our armamentarium for dry eye management, as well as gave us confidence to use the molecule in our moderate to severe dry eye cases with confidence and assurance of improvement in parameters. So as a summary, I would say that it's a good addition to your armamentarium, and you need not always wait towards the end of going into severe dry eyes. You can start it as an early molecule because it does have a different mode of action, because we don't want the inflammation to set in. We don't want the inflammation to go into a positive or rather a negative feedback cycle. We want to reverse it as early as possible. But you should select your patients, because all patients may not have a similar type of exposure to damaging effects. And if you know that this patient is going to go into an irreversible cycle sooner rather than later, you could add this molecule earlier along with your lubricants. And if you think that patient is under controlled conditions and is following your regular precautions and taking breaks and things like that, and it does not have any immunological disease, then you can wait for starting Lifitegrast. But as of now, if you ask me, I am not fully moved on to Lifitegrast, but I definitely given it preference to cyclosporine because of the faster effect and lesser lesser complaint as of now for my patients. And compared to in this study, I found that it has given additional benefits. So therefore, I would like to share 2 of my cases which where I had used Lifitegrast off-label. So there are off-label uses of this molecule. You can use it in allergy, you can use it in injuries, chemical injuries, you can use it in cases where there is neurotropic keratopathy, you can use it post transplants to prevent rejection or to avoid the use of oral anti-rejection drugs. So these are the off-label uses. So one of them is this case. So here this case, Neurotropic Keratitis, which was treated with Corneal Neurotization. In this case, what I would like to acknowledge my colleague Dr. Sunil Morekar, who is the ocular plastic surgeon who is, works with me at my institute, and we have done a lot of these similar difficult cases. 70-year-old female with history of diabetes, herpes simplex virus keratitis, recurrent infection. 6 months after her last episode, she presented with another episode of corneal ulceration or rather epithelial defect, and she was diagnosed that this is a case of recurrence of HSV. Started on oral acidic topical ointment for more than a month. It was going on along with antibiotic drops. The ulcer still progressed in spite of treatment and became geographic, and then it was referred to us for further management. We found that there was a large ulcer with rolled over edges, corneal edema, central opacity, and thinning at the center. And there was scrapings were done to rule out fungus and bacteria. The patient was tested for corneal sensation, and they were found to be almost zero on esthetiometry, and severe dry eyes were seen on subjective testing. The patient progressed to a large corneal med, which is the Mackey classification of neurotropic keratopathy with a flat anterior chamber, and the vision dropped from 618 to P8. Thus, the diagnosis was neurotropic keratopathy grade 3, not 4, due to HSV and diabetes together. An element of neurotropism complicated this case. So we decided to go ahead with what is known as a sural nerve transplant, which is done for corneal neurotization. And because it was already perforation, we had to do a tectonic plasty, keratoplasty, and a sural nerve was used because all the 4 quadrants were having almost zero sensations, and we had to cover the entire cornea with the transplant. The surgical plan was to use therapeutic PK with sural nerve transplant to treat both the perforation and the neurotropic cornea. And harvesting of the sural nerve was done as we were conducting the therapeutic PK. So while we were doing the transplant, the plastic surgeon gave us the sural nerve from the foot, and then after that we followed up with the ipsilateral sural nerve graft. Now in herpes simplex, why we can do ipsilateral graft? Because the forehead sensations are spared. In herpes zoster, the forehead sensation is also affected. So you have to go from the connect the sural nerve from the contralateral trochlear nerve to the cornea or around the limbus. So this is the video which shows harvesting of the nerve, the medial cutaneous branch of the sural nerve, and we take about 10 centimeters of this nerve, and then we perform this procedure where the nerve is connected from the, in this case we did ipsilateral, but we can also do contralateral in case the forehead sensation is also affected. So the supratrochlear nerve is now getting connected to the sural nerve. You have to open the sheath properly and connect it. You can also use glue in these cases instead of suture. And then it is broken into fascicles, and each fascicle is then brought down under the conjunctiva into 4 or 5 quadrants around the cornea. You can take scleral tunnel-like incisions to place these fascicles, and then the overlaid conjunctiva is then sutured. So these fascicles can be attached to the area with the help of sutures, or even glue can be used. And then after this, as we saw, this was the preoperative condition of the patient, the corneal nerves. And after post-operative, you could see the nerves going into the cornea with the help of confocal microscopy. And this was the epithelial effect initially, which reduced after 4 weeks, and by 8 weeks it had healed completely. Yeah. And the vision and stereometry scores also improved drastically. Usually by 2 months the epithelial effect heals, but the sensations they return by 6 months. So the score improved to around 50 afterwards, and the vision also improved to original vision of 6 by 18. And after 1 year also, there is no further thinning or perforation. But in this case, we are still using this immunomodulator drugs. So you can use Lifitegrast in these cases to improve the dryness, because it also reduces the inflammation. It also improves the surgery results of the surgery, because the nerves have to grow into the cornea, and reducing the inflammation helps. So this is a one off-label use of this molecule. This is just the graphic representation. And stem cell function recovery is the most important thing in neurotization. Why does the epithelial effect heal? Because the limbal stem cells need the neurotropic effect of the nerves to grow. And this is the study which shows that stem cell function depends on the neurotization. And VEGF-A basically causes vascularization, and VEGF-B causes neoneurodization. So if the nerves reduce, if the VEGF-B decreases, then the VEGF-A increases. So then your cornea gets vascularized, and if you increase the nerves, the VEGF-A regresses and the vascularization reduces. Some people say in HSP the nerves may reduce spontaneously, but this study shows spontaneous regeneration of nerves is not very good unless you do a neurotization. So it's a definitive treatment, and we have Oxervate, which is a nerve growth factor available in UK, but it is very expensive, almost around 8 to 10 lakhs per vial, and it has also shown promising effects, but sensations have not improved so much as compared to this kind of a surgery. And various studies have showed comparable results with our case. And this was the latest case done recently with a collaboration, where you can see how the vascularization pre-op and 60 days post-op has completely changed. Epithelial defect has healed, and the opacity is also reduced. In conclusion, neurotization is effective. It is a good for recovery of not only the healing of the epithelial defect, but also improving sensations, vision, and corneal integrity. And VEGF-B plays a major role. There is confocal immunological genetic evidence of growth of nerves. It inhibits vascularization, and nowadays we are doing endoscopic and robotic neurotization also, which reduces the inflammation further and gives better perceiving. So this was one off-label use. And the second off-label use was in our other case. This is a case of grade 6 chemical burns. So this just shows how we can do a good stepwise approach to such cases. A 12-year-old girl came with a tuna splash with ice, and the vision was completely lost. It was PL vision, grade 6 alkali burns involving everything: sclera, cornea, parenchyma, and the skin, eyelids. Thorough wash was given on day 1 with removal of visible lying particles, and started on steroids, antibiotics, lubricants, vitamin C. Amniotic membrane was done immediately next day to cover the ocular surface as well as the eyelids. And a simulacrum ring was placed. 15 days later, when the amniotic membrane started getting dissolved, we repeated the same, and we continued with the simulacrum thing and topical steroids. 1 month later, we decided, because there was the epithelial defect was not healing, everything was going into a melt. We decided that we had to do denoplasty. Then we actually vascularize the area around the limbus with the help of tenons by pulling the tenons towards the limbus. But we also did a micro slit. We took some cells from the opposite eye and fixed, because we didn't want to do a cadaveric slit in this case to heal, because we thought that is a small child, and therefore to reduce the inflammation we used a slit from the other eye, so stem cells from the other eye, and also did a tarsal tenoplasty. After that, we found that the simulacron, and there was some simulacron left, but the epithelial defect had healed quite well. So to reduce the simulacron, we did a conjunctive autograft. Again, amniotic membrane, repeated a slide again, a little more, few more stem cells were taken, although it is not as well as able to do slide from the good eye. But we had taken very small tissue in the previous case, so we took another small tissue now and released the ectropion. And after that, we found that almost 4 months, 4 to 5 months down the line, no inflammation, no simulacron, no ectropion, and very mild vascularization. And patient was on low potency steroids. And here also we can have the role of Lifitegrast. Girl of 12 years, and with so much of inflammation, vascularization, there is bound to be a dejection. This is the place another off-label use of Lifitegrast. So 1.5 years later, we did frontline transplant. We did microcautery of the blood vessels, topical steroids, and preservative-free lubricants were started, and topical tacrolimus in this case, and hazard-therapy. And then, as you see, the epithelial effect started early. The bandage contact lens was used. It healed completely. Vision improved to 6/18 in this case, and later on to almost 6/6 parts. This also was covered by the local media. And so follow no epithelial defects today, almost 2 years down the line. Patient is on Lifitegrast, and now we have stopped therapy. In fact, I started Lifitegrast in the last 4 months, sir, because ointment was becoming too much for the child, and drops were easier to use, and lubricants, and there is no epithelial defect. The vision is 6/9. No staining of the cornea and corneas distal care as of now. So stepwise management, patience is the key. You can use multiple procedures. AMDs guide tenoplasty, commit level, eyelid correction, microbody corneal transplant. Final stage of transplant should be done by everything is nice and clear and corrected. And then you can manage it, medical management, of which features above Lifitegrast as a molecule can be used for reducing the inflammation, which is a steroid sparing molecule. And of course, then there is no question of IOP and other things. And always call the patient regularly to see if there is a chance of rejection. So we plan immediately approach and all these procedures. Thank you very much for patient listening. So, this is which we attend off label, and the study which we did on Lifitegrast. How we just quickly before we start dinner look at few clinical scenarios, and we'll ask the panel to comment on that. So,
That's very well.
Then it is used data and be pressed. Yes, ma'am. You said that immunization into the stem cell is right?
Yes.
See the ocular sepsis diseases. Why don't you view keratitis before being a spread?
So basically, neurodialysis is specifically left for neurotropic keratitis, and neurotropic keratitis has very specific causes like diabetes, herpes, then tumors of the base of the brain, then trauma, and such cases. So it's not done in all cases. If your corneal sensations are both, if you are in dry eyes, basically your sensitivity, your got of pain, your photophobia, that itself says that the nerves are alike.
So what if I will say ocular surface burns where the surface is entirely
But burns is not it's only superficial loss of nerves, just like a post-ASIP or post-cataract. It's not a deep damage to the trigeminal nerve or anything like that of that side. So
that it's not for for the impact of the now it's but I means that the overall in a sexual environment.
actually what it does is there are two theories. One theory says that the nerves grow into the cornea, which we don't believe. We feel that it is the neurotropic effect. It stimulates the stem cells in the corneal trauma to produce new nerves in that area. So it just improves the mellow of that area and causes the growth of nerves in the cornea. Because if you see post, yes, some many patients, many doctors, what they do is they do a keratoplasty later on.
For 6 months, they let the nerves grow and then go. So if it was a nerve which are growing from the back side, immediately post steroid, you have already cut everything that is worn. So then, no. Again, it will lead to neurotropic effects. But that doesn't happen because the environment changes. The stem cells are stimulated to produce few nerves in that area. So we are looking at some nerve providing neurotropic effect. If the trigeminal nerve is alive, then we don't have to go now the aspect. And the second question is that the root set they will keep use of it pickup. Right? So in computer vision set boy. Now these patients can use it for 4 months, 6 months, but that the stimulation is not required. It needs to go into the computer to the right of so how take it which all repeating and how repeating. So basically is uh, the lifestyle monitoring has to be done. The computer user has to be taught other things also. You cannot depend on drugs all the time. Basically, when they compare, they don't have any precaution. They're just using light tap and send the rikapai in the day. So that all those things have to be taught and slowly and better that. So as I said that the Buffalo also said that you have to keep it out for a long time to see the real effect coming. Like for upper study was 84 days. So if you stop it, it's obviously bound to increase the inflammation because the T cells inhibition will stop. But by that time, if you have changed the environment and the other things around the patient, and basically how does the T cell get activated? That this environment causes the epithelium of the cornea and the cornea to release these LFA molecules. So in the ICAM. So then that part has to be controlled. Taper it down and there is no taper, it's just a isonators, sort of like steroids. Can I ask what is the cost of the Lifitegrast item? Ashok, we'll cut down the cases story and thank you Ashwin for the excellent talk and sharing the insights about the off-label use of the molecules for the order. And thanks for coming on the date from Nova, everybody. So, I have one question. Is there a minimum 8 kilo which we can't give Lifitegrast? Each. So minimum age that we can prescribe Lifitegrast. Minimum age is 18 years. They were done studies, so that's what they say 80, but I see though that in young children you are giving tacrolimus anyways or allergy. I'm sure. इसको no आ रही है higher exercise covered type. So because screen stress technology tech worker. So I would like to ask the panelists, Reemat, how do you deal with this? Or the panelists in front, 30-year-old male, anyone can take this. Anybody, corrupt audience can also comment. A 30-year-old male, high visual demand. This is a very common case that you see in your day-to-day life. And pivot of 6 is less. OSDI modify anything more than 22 is bad. OSDI. So discussion point rapid relief versus long-term immunomodulation impact on work productivity. The productivity is also important. So we want something which has to be given not very frequently, gives better effects as well as no modifies what is going on in this space. So how would you Saturday my so as such, if you have this patient coming to you and what you start initially at the hub your test. First of all, the most important thing is outside. Outing the patient above the core with the triad and the light side monitors. That is the most important thing because even if we check the triad, it's going to reconnect we do to those checks. But that one thing is that depending on symptoms and site, we can start with either only duplication or better with duplication. The therapy I said we start with steroid and that shit to the cyclist for weeks and continued for 3 months, and he goes 8 months in the vice my colleague. At I continue with the CX or KT vector as in the keeper. So the basic insights in this is that they want support in screen exposed protect. They want faster relief. They want lesser use of drops, and they want favorable compliance. Then only it will improve the productivity. So as madam said, this medications, specifically this molecule, will definitely give trust. Another case of postman positive. We'll just finish it 200. Is it okay? So patient characteristic: 58-year-old female, high symptoms, normal summers, frequent artificial tear use. She's using artificial tears every day, but she's poorly compliant. Postmenopausal role of neuroinflammation and other things, role of hormones. And can Lifitegrast work in like this sufficient dry eye disease? The actress is sufficient. It's not deficient. The tears are sufficient in this case. It's basic. It is basically a neuroinflammation. This different type of inflammation not related to the actress because of the hormone. So again, in this case, you can add this molecule. It can add up to your regular medication. And the last case is auto case if you might have people take the yes, the method, yes. But I have seen many after 4 or 5 years of postmenopausal, they usually draw away also. An autoimmune leak dry is the last case, diagnosed with Sjogren's syndrome on hydroxychloroquine. Some of you have used that before also. It was available in the market. Severe dryness, OSDI very high, 65, summers less than 5. So this is an autoimmune case as we discussed. Sir would like to comment. Who is me? Have you heard? Okay, sir. One of it. So this case of autoimmune, 42-year-old female of Sjogren's syndrome. Till बोलने पूर्वी से बैठे हैं कर दिया खत्म करती है and what phase of autoimmune dry more refractory when do SEL beyond artificial tears and can it give even safeties? Because these are pertinent questions and we know all the answers after the discussion. Because of the like surprise. But first, you need to hear what autoimmune dry more refractory. It's more refractory because you need the real good for. Correct. Because the root cause is not big, no more in the symptomatic care of you or the root cause treated, and then you know to the ocular success statement in the form of moderator plus yeah. So these are the common scenarios. There are many others, but we'll stop here. And I think we had a nice discussion and hopefully you benefited. And I thanked again in IDOS. I have actually have my relatives in Ujjain. Dr. Madik is my relative. He knows it. William Madik. So and I was going to go to Jen, but he wanted me to give a research to buy a ticket for all the points. Like, up here.
Sure. So as well, sir, it is wonderful talk and my emails on the Lifitegrast attitude. I'm sure Varupas have taken many points today and you're going to use it in our practice. I would like to call a sympathetic right now.